Hi, good morning, everyone. I'm going to be talking about emergency department overcrowding. Just a brief overview. We're going to be discussing definitions. What is overcrowding? What are the signs and how is this measured? The causes and contributing factors, consequences for patients, for staff, and for the hospital system in general. And then we're going to talk about what we can do about that, whether that's at the local level or systemic, and wrap up with some key points. So what is overcrowding? Do any of the residents want to give me like some words that come to mind or like does this image trigger anything for you? Long wait times, two hallway, interruptions. Excuse me. Okay. I need to pee. Great. Yes. We're on the right track. So overcrowding is defined by the American College of Emergency Physicians as a situation that occurs when the identified need for emergency services exceeds the available resources for patient care. So this has been identified as a problem since the 1980s. In fact, the first conference addressing ED overcrowding occurred in New York, involving New York ASAP, EMS, the Department of Health, and legislators that convened in 1987. And then in 2006, the US Institute of Medicine declared ED overcrowding to be a national epidemic. Overcrowding happens typically in ERs with annual volume greater than 40,000 patients. So this phenomenon is evident by multiple things. We mentioned excessive wait times for patients both in the waiting rooms and EMS patients waiting to be triaged. Use of alternative treatment areas, treating patients in chairs or hallways, for example, two hallway, and obstruction of entry and exit ways. Think about the ambulance bay triage line. Sometimes EMS refers to this phenomenon while they're waiting for triage as holding the wall, kind of like Jon Snow in Game of Thrones. And then, of course, prolonged boarding times. So when we're talking about boarding, we're talking about patients who've been evaluated by the ER doctors. They've been dispositioned to either an observation bed or inpatient bed, and they're physically waiting in the ER for a bed to become available. So as demonstrated by these signs of overcrowding, it's clear that these events together lead to dysfunction of the emergency department. The fact that the number of patients exceeds the physical or staffing capacity of the ED. This is not just a problem for the emergency department, it's also a problem for the entire hospital. So how did we get here? In 1975, there was about 1.5 million inpatient hospital beds in the US. That's one bed per 143 people. And during this time, most admissions were planned admissions. There was a very small percentage of unplanned admissions. The hospital functioned more like banking hours, 9 to 5. Now, as of 2025, with approximately 900,000 inpatient beds, we're looking at one bed for every 390 people in the US. And this is in a time when a majority of hospital admissions are unplanned and fed by the emergency room. So in addition to changes in hospital functionality over the past few decades, we have to consider that the population has increased by 50% in the last 50 years. Life expectancy has increased by double digits. People are living longer, aging with more disease, and having more complex medical illnesses. So we talked about these signs of overcrowding. Let's talk about how this is objectively measured. So there's multiple scoring tools, things like the National Emergency Department Overcrowding Score, or NEDOCS, the Community Emergency Department Overcrowding Score, CDOCS, the Severely Overcrowded and Not Overcrowded Estimation Tool, or SONET, but there's no single measure that's been used universally. So these factors, having high wait times, providing treatment in hallways, obstruction of entry and exit, and long boarding times do correlate with many of our operational metrics in the ED, which is helpful for tracking the presence and severity of overcrowding. So we're talking about things like the time to provider, the ED total length of stay, which we typically use time to disposition because we all know that the moment that you click discharge, the patient doesn't just disappear. And lastly, the number of patients who leave without being seen. So what are the causes? First, we have to talk about the input factors, and this involves like the sheer volume of patients coming in. These factors are things like having a safety net hospital, a large uninsured patient population, working at an academic facility, high volume centers, rural areas, places with poor primary care, high volumes of low acuity presentations, frequent utilizers or frequent flyers, working in an area with limited access of diagnostic services in the community, and then the number of escorts with the patient, which has been shown to negatively impact ED workflow. So all these input factors lead to increased admissions, particularly when you consider new and unsatisfied needs in the community, progressively aging population, and increased number of complex patients. When looking at these factors, it's important. We can see that not many, if any, could be controlled by the ER alone. So throughput factors, on the other hand, are those that affect the time to process and treat patients in the ER. This involves things like the bed availability in the department, staffing shortages, the number of tests required to be performed and delays in these test results, the presence of junior medical staff in the emergency department, the degree of gravity of a patient's medical condition. Think about like the time and staffing it takes to work up and treat a level 1 trauma patient as opposed to like an ESI 4 with ankle pain. And then long consultation times. So throughput factors are where we start to see some opportunity for interventions to improve the overcrowding. And output factors. This is the volume of patients leaving the ER. And basically, what's causing this is something called exit block. And this is when patients are unable to access beds in a reasonable time and due to general lack of available beds. As we know, this causes boarding. So just so we're all aware, this was new to me, the U.S. Centers for Medicare and Medicaid Services define acceptable boarding time of 6 hours. So factors that lead to exit block include inability to receive adequate home care, or patients who have difficulty accessing follow-up care. Think about like undocumented patients, uninsured patients, inefficient planning of discharging patients. This kind of relates to the previous point. I'm sure many of us have been in the situation where you're focused more on like the medical complexity and diagnostic workup and not really considering the social factors at play that are going to prolong your disposition. And then obviously bed availability and delays in transporting patients to the unit. So consequences are not insignificant. Multiple studies have shown an increase in all-cause inpatient mortality, increase in treatment and medication errors, increase in time to antibiotics or time to analgesics, and an increased need for hospitalization the longer a patient waits to see and be treated by an ER doctor. Increase in hospital length of stay, and then our vulnerable patient populations and those with, like poor or little or no insurance and complex medical conditions often have difficult care access and poor quality. And then, of course, low patient satisfaction. Think about the times where you've admitted a patient yesterday, possibly 2 days ago, and they're still in the stretcher asking, when can I go to the bathroom? When can I eat a meal? When can I have a good night's sleep? And then, of course, this affects providers and staff. Burnout is nothing new in the profession of emergency medicine, and overcrowding and how it affects your ability to see and treat patients is a large contributing factor. It's not surprising that this attributes to poor job satisfaction and high turnover rates, increase in workplace violence. And then lastly, I think it's important to talk about the mental health impacts. With an overcrowded ER and understaffing, there's not a lot of opportunity to process difficult experiences that happen frequently. We're dealing with high stakes cases, sometimes like violence towards staff, patient deaths, and this can all have a cumulative psychological impact, particularly when there's pressure that dissuades appropriate time for debriefs. And lastly, of course, there's financial impacts. So this study that was done by UC San Francisco, conducted from July of 2020 to June of 2021, they looked at the financial impacts of boarding. So in their study, they included a total of 54,000 patient encounters, and that was 7,410 boarders annually. And the total minutes spent boarding was 3.7 million. So the average length of stay at this hospital this emergency department during that time was 395 minutes. So they divided the total number of boarding minutes by how long it typically takes to see an ER patient and came up with this number of 9,576 missed encounters is what they're calling it. That, the opportunity was missed to see ER patients due to the presence of boarders. So at this institution, they used their average cost for all comers, which was $780 per visit, multiplied that by their average reimbursement rate, and came up with a lost revenue of $1.7 million annually due to boarding. So let's talk about how it works at our institution. So we talk about this number of patients who leave without being seen. I like that was a discussion we had, right before starting this and why it matters. So this is essentially equivalent to lost revenue for the hospital. And as we saw in the previous study, different hospitals measure this in different ways. After talking with Dr. Youssef, I just wanted to, outline how we predict revenue leakage from our emergency department. So using algorithm and data, they're able to predict basically the ESI of all patients who leave without being seen, and then the percentage of those patients who would require hospital admission. And at our average ER cost and average reimbursement rate, we can see that 1% of patients who leave without being seen means an annual revenue loss of $400,000. So over the past couple of years, we've had an improvement in our percentage of patients who leave without being seen by 5%. And that's been sustained for over a year period of time, which means we've presented, revenue loss of $2 million annually. So what can we do about this national epidemic? When we talk about micro-level strategies, that's changes made at the level of the emergency department. So things like implementation of fast track area for lower acuity complaints, having a triage liaison, a triage team, or a provider in triage pivot, doing more point of care testing, shotgun workups or upfront expedited diagnostic workups, secure messaging with consultants, and then the presence of ER scribes. So Fast Track has shown to reduce waiting times and improve patient satisfaction and also reduce the number of patients who leave without being seen. In a 2024 systematic review and meta-analysis published by our own Dr. Youssef et al. Demonstrated. So having a triage liaison or triage team or provider in triage has shown to decrease time to disposition by 28 minutes and was more effective in reducing the number of patients who leave without being seen when compared to routine triage. Point of care labs, including labs like glucose, electrolytes, renal function, blood gas, troponin, pregnancy testing, and UA, when compared to standard laboratory evaluation, has shown to decrease the time to disposition by as little as 5 minutes and as many as 96 minutes. Upfront expedited diagnostic workup has been shown to reduce the length of stay and time to disposition by at least 20%. And then secure messaging with consultants like Epic chatting or WhatsApp is what was used in the study. When compared to standard phone communication, has been shown to decrease the median consult time and the length of stay. And then scribe use in the emergency department has shown to possibly reduce length of stay. So at the systemic level, macro strategies, we talk about things like the observation unit. And I think we're all aware, but this is for patients who've received a diagnosis or starting a treatment. We don't anticipate a prolonged hospitalization, but they do need to be observed for a short period of time. The presence of ED observation units has been shown to improve overcrowding, improve overall patient workflow. So you can see why during times, for example, where our OBS unit is under construction, it's pretty critical that there's multi-departmental collaboration to keep this unit up and running. Things like a surgical schedule flex for elective procedures. This would be like patients who will require a post-operative inpatient stay after like an elective joint replacement. For example, having those procedures scheduled during like lower volume times has been shown to be like an effective patient volume control strategy. And then space utilization has been proposed. I thought this was interesting. So what this means is boarding patients in inpatient hallways rather than in emergency department hallways, meaning it's typically a quieter area. It's closer to the physician team that's taking care of the patient, as well as being physically closer to the unit where they're assigned. This has been shown to alleviate strain, and it was actually preferential to patients when compared to boarding in the ED. Things like early discharge, meaning before 12 p.m., has shown to lead to an overall reduction in length of stay. I know, like on the inpatient units at downstate, they push very hard for like a discharge before 12 p.m. on medicine units. Weekend discharges can also substantially increase bed availability because the number of discharges on weekends is typically 50% lower than weekday discharges. And then lastly, like legislation and guidelines, having some precise guidelines and openness for organizational change, because as we can see, there's no single solution, and many of the interventions that we have talked about involve multi-departmental change. So just to wrap things up, so crowding occurs when the need is greater than the resources available. Input, the volume, the coming in, we really don't have any control over that. What we do have opportunity for improvement is the throughput, the amount of time it takes to work up and treat a patient, and then getting them out of the ER. Consequences are bad. It's bad for patients, it's bad for staff, and it's costly for the system. What can be done about it and what has shown to improve is things like fast track, more point of care testing, shotgun workups, having a provider in triage, epic chatting consultants, the presence of scribes, and then system-wide what has shown to be effective, the OBS unit, these things that we discussed. So, I mean, I just wanted to like finish up with future directions. I think it's an ongoing effort to improve care and safety for our patients and mental health and job satisfaction for our staff. And then I want to thank the admin team, Dr. Youssef, Dr. Benson, Dr. Chu, and Dr. Gibson for their help with this. And that's my resources.